everybody. Thank you for spending your lunch hour with us. Welcome to the Think Global. I am so excited to have this team here with us for this Think Global called Breaking Cycles, Intergenerational and Community Approaches to Youth Mental Health. Just as a reminder, we have a Zoom audience and they are recording also, and we'll post this. So that will include your questions and discussion. So just want to make sure that you know. I am Eve Puffer. I'm an associate professor in psychology and neuroscience and here in DGHI, and I direct the Duke Center for Global Mental Health and have the privilege of being the moderator today. And I'll introduce our theme briefly and then pass it to our three panelists who will share a little bit with you. You'll have time for questions for you all and for the online audience, a little bit in between their presentations, and then we'll try to save the second half really for moderated questions and Q&A for you. So please think while you're eating about what you're curious about, because we'll just give you a flavor and then see what you're most interested in talking with us about. Just to introduce the overarching topic of what we're talking about, we want you all to be thinking about how an individual, all of us as individuals, are influenced by factors at multiple levels. So all of the behaviors that we engage in, the mental health symptoms we might experience, are influenced by individual factors, but also by interpersonal factors, community level factors, the policies that we live under, and the culture that we live in. Today, we are going to focus in on that interpersonal level and thinking mostly about the family and how adults and caregivers in family, their behaviors, their symptoms can influence the symptoms and behaviors of the children and adolescents that also live with them and around them. We're going to think a bit about the risk cycles, the intergenerational cycles of risk, thinking about how some of these behaviors and symptoms can be passed down from generation to generation in very complex ways through modeling, through genetic factors, through environmental exposures, and the ways that those interact. We're going to think about that in just a few examples of where it's true. So one is in substance use. So globally, about 400 million people are living with alcohol use disorders, 13.1 million young people with almost 60,000 alcohol-related deaths. And this is from 2019. We're going to think a bit about intimate partner violence, remembering that 1 in 3 women will experience physical or sexual violence in their lifetime, and 24% before the age of 20. And when we think about mental health, which is, of course, a risk factor and an outcome of many of these experiences, half of people, so half of us globally, are at risk of having a mental health disorder before age 75. And up to a fifth of children and adolescents worldwide right now are experiencing mental health disorders. With that sort of challenging set of backgrounds, we do have some messages of hope and some promising approaches that we hope to talk a bit about today, where we can turn some of those risk cycles into protective cycles. We're going to talk today about multi-level interventions that look at the whole family, individual caregivers, and adolescents themselves, and think a little bit about an integrated model where we can work together to break intergenerational cycles by strengthening overall family relationships, also engaging fathers directly, so one way of reaching caregivers individually, and then engaging adolescents, both groups of adolescents to talk about their relationships, and individual adolescents to address their own risks. With this work, and the 4 of us have been working together for many years now, we take mostly community-based participatory research approaches, whether it's in the community or the clinic, involving the people that we're working with. Community-embedded implementation, and that can be out in community-based settings or clinic settings that are not mental health specific settings. So we think about that as community embedded implementation. We use task sharing across all of these interventions, and that's training non-specialists to provide some of these interventions, things you might think a specialist is needed to do that actually can be done by people's peers and their fellow community members. And all of them have aspects of mental health care and then integrated relationship strengthening. So I am excited for you to hear a couple of examples from each of our panelists. We'll first have Dr. Ali Justo, who is a clinical psychologist. She's an assistant professor at Florida International University, and she'll talk about an intervention that she and Dr. Jaguga and other colleagues in Eldoret, Kenya have developed. Then we'll hear from Dr. Florence Jaguga, who is a DGHI visiting scholar that many of you might have met over the past couple of weeks. We're delighted to have, and she's a psychiatrist, and she directs the mental health and rehabilitative services at Moy Teaching and Referral Hospital. So they miss her very much there, but not sure. I think she's happy to have a tiny break, but is very much in demand there and has a very big role at MTRH. And she's going to talk about the direct services to adolescents, looking at early intervention for substance use. And then Dr. Savannah Johnson, who's also a psychologist and a postdoc at Massachusetts General Hospital and Harvard University, is going to talk with us about Prepared, which is an adolescent mental health promotion and IPV prevention program. So we look forward to hearing about 5 minutes from each of them about these interventions, and then I look forward to your questions and ideas.
Hi, everyone. I'm Allie. Oh wait, I'm in the South now. Y'all are the quietest. Like, it's so quiet in here. Please feel free to crunch, and people are eating lunch in front of us, so feel free. So I am really happy to hopefully very quickly keep me honest. In 5 minutes, tell you a little bit about some of our work in Eldoret, Kenya, specifically about our intervention LEAD, which stands for Learn, Engage, Act, Dedicate, and it's an intervention to improve depression, alcohol use, and positive family engagement amongst fathers specifically. As with all things, this is our amazing team in Kenya. Mine is Dr. Jaguga, who is sitting right next to me now, so who's welcoming me to do, which is really fun, in Eldoret and here. But our amazing project coordinator, Dana Bori, Winnie Mania, and our amazing team of supervisors and consultants. Not without, none of this would be possible at all. But briefly, about the why, fathers and men have pronounced impacts on family systems. When dad is doing well, we see improved family functioning, positive co-parenting relationships, positive parenting, and increased positive youth mental health outcomes. When dad is struggling, we kind of see a ripple effect in the opposite direction. So more family conflict, risk of violence in the home, poor parenting, and then predictive of poor child mental health outcomes. And here I'm thinking about alcohol use as well as depression. Despite the impacts and men's desire to be engaged in their families, fathers are engaged in treatments for themselves and for their families. So family-based treatments where you're trying to strengthen the whole family, at much lower rates than mothers. So initiating rates of treatment at 4 times lower than women. There are a lot of barriers to engagement. Struggling with mental health or alcohol use in and of itself can be a barrier to engaging in treatments, especially if it's a more family-focused treatment. A lot of our family-focused programs, so a parenting program, actually sometimes code for mom only, implicitly or explicitly, and often these models can be deficit focused. So what's wrong with you? Please come, you have a problem. This doesn't work great for most people, and particularly doesn't work well with men. There are social and cultural barriers, so masculine norms and gender norms that often discourage help seeking. And then there's structural barriers that we see globally, a lack of providers. And often the times we might be offering programs might not fit with schedules that men might keep. So going and providing for your family might be hard to come in the middle of the day. similar to that first pattern of father mental health to child outcomes that I presented, we see a similar pattern when we did some formative work in Kenya, speaking with dads and speaking with families. We were really hearing from fathers that, yeah, we'd like to be involved in things, and we love our families, and we are feeling that this huge amount of pressure to provide for our families. But there's a lack of economic opportunities, or it's difficult to provide. And when I can't meet this standard that I have, I'm feeling depressed. I'm feeling like I have no purpose. I'm not sure how I fit in my family. I'm not sure how I show up. And then often engaging in drinking behaviors, one, to cope, but also to engage in social support. And that this in turn is leading to spending of family finances on alcohol use, where things that might be going towards things like school fees are instead maybe going towards alcohol. And these things kind of all together is leading to this disrupted parenting, fighting around alcohol use, increased risk of harsh treatment, both in the context of alcohol use, but also fights about alcohol. So fighting when you're intoxicated, but also fighting about drinking, and then increased child distress at home. So that got us really curious around how do we address father mental health and substance use and better engage dads with their families. And I think really how can we expand and leverage and build upon this role of fatherhood to both address men's mental health and depression, but also improve family outcomes. And so this is what led to LEAD in Eldoret, Kenya, all in collaboration with Boyd Teaching and Referral Hospital, and then AMPATH, our academic model providing access to care. It's a consortium of North American schools, MTRH, and the Ministry of Health in Kenya. And with our team there, we collaboratively, found it out. I'm eating too, you just can't see it. In my mind. The team developed a 5-session intervention for father depression, alcohol use, and family engagement for delivery by peer fathers in the community. This is really rooted in motivational interviewing, which is an efficacious treatment that we have for substance use, but also for engagement more generally in other treatments. The goal of it is to increase treatment engagement and readiness to change in order to improve alcohol use. It is also a really strength-based program and has some really nice principles around empathy and people showing up as experts in their own lives. Then we also use behavioral activation, which is an efficacious treatment for depression with signals of improvements for comorbid substance use. So if you're experiencing depression and also struggling with substance use, it shows positive effects. And the idea is you choose values for yourself. And in our intervention, you choose a value for your family. And you begin to schedule small, achievable, positive activities that are value aligned in order to sort of increase positive, healthy behaviors and replace unhealthy patterns and improve mood. And then we also included masculinity discussion strategies. What does it mean to be a man to you in your community? What helps you in your life? What hurts you? What was your dad like? What do you want to take with you? What do you want to leave behind? In order to kind of expand conceptions around dad as being provider only. And we designed it for father delivery. So we had peer fathers, so other men in the community who are seen as role models, nominated by community leaders to deliver the treatment. This is Susan, one of our supervisors, supervising a few fathers, peer counselors in the study. We did a proof of concept of LEAD, a small pilot trial, really tried to maximize our learning, and we found we were able, our target was 10 dads to start. We were able to get 9 to begin treatment, 8 fully completed, attending a lot of the sessions with really positive improvements in father mental health. We saw promising signals of change in family functioning, dad's involvement in family, and even mom and kid reported positive child mental health and mental health outcomes for themselves after. We used a multiple baseline single case series design. You can repeat that back to me now. And this is just a really nice way to maximize learning with a small sample. So we really wanted to dig into our alcohol use findings. And it's a design that let us more confidently say we think it's lead that is driving some of the changes we might be seeing. And so we saw at the follow-up period, fathers in the treatment were 5.1 times more likely not to drink on any given day. And when they were drinking after treatment, they were drinking 50% less. So now we are doing a randomized control trial of lead in a hybrid type 1 study. So we're trying to see, is it really working for depression and alcohol use, while also exploring some of these implementation outcomes around peer father delivery. We are enrolling 102 DAB. We actually have our full sample enrolled and are in the middle of the trial right now. This is our lovely team doing all the work on the ground. So it's our counselors, our supervisors, and study staff who are really the heart and soul of the project. So a quick thank you to our team in Kenya and our team in Miami too at FIU. And thanks all for your time and attention today. And you're during your lunch.
Yes. Good afternoon, and thank you for having me. I'll be talking about an adolescent substance use brief intervention that we piloted in Kenya in response to the large substance use burden among youth in the country. So in Kenya, 12.2% of adolescents were found to have any mental disorder, and the prevalence of any alcohol use disorder was 5.8%. But unfortunately, access to treatment is very limited because of few mental health providers, a few services, particularly that are youth focused. And studies show that only 2% of people with mental health and substance use issues have access to care. Substances for young people have impacts that go beyond the young person to future generations. Studies show that substance use has negative consequences for their own mental health issues, for their own education. It causes negative outcomes in terms of their education, results in a poor quality of life, contributes to chronic diseases and HIV, as well as adverse social and family outcomes, poor relationships with family and friends. And this contribute to each other in a vicious cycle, and not only affects the young person, but future generations as well. And also studies are showing that this effects of substance use and also the mental health issues that arise from substance use do affect the genes in an epigenetic manner, and those again can be transferred to future generations. So the impact can be very profound for substance use among young people. So we tested substance use screening and brief intervention. And the goal of this intervention is to motivate people to reduce or cut down substance use, or even to engage with more intensive care, if they have high risk patterns of use. And the rationale for picking this substance use screening and brief intervention was that it's easy to scale it. It's a simple intervention. It's easy to scale it. It's easy to train lay providers to implement it. You can easily integrate it into multiple settings. So this can be integrated into the school setting, in primary care, in the criminal justice system. It's something that can be transported and embedded into multiple systems. So we saw this as something that was, had multiple advantages. I'll describe how the intervention looked like. So it had two main components. A screener which is a set of questions that asks about involvement in substance use. And the tool that we used to screen for substance use was the assist. That's how the manual looks like, that you can see there on the left. The assist asked about use of various substances: alcohol, tobacco, cannabis, amphetamines, and so on and so forth, a couple of substances. And then assigns a risk level, based on, the young person's involvement in substance use, which can be moderate or high. And then based on, the level of involvement of group use, you implement a motivational, interviewing session, which is the brief intervention. And that lasts about 12 minutes. So we adapted that brief intervention from the World Health Organization manual that you can see there, that was already available and developed by the World Health Organization for use in the primary care setting. Of course, there are various other manuals that have been developed for use, but we specifically picked this one because it had been developed by experts from the world. So the main components of the brief intervention, a core one is giving feedback to the young person about their scores, telling them what their scores look like, what that risk level looks like, and the harms related to that risk level. And all of that, is in the intervention. And then giving advice to cut down or to stop using, to avoid getting the harms related to substance use. And then having a discussion about, the pros and cons of substance use, an assessment of readiness to change. And during these discussions, change talk is elicited from the young person, and the brief intervention, that the goal of the brief intervention is to make sure that the young person takes charge of their and makes decisions about their own substance use, so that the change talk doesn't emanate from the provider, but the change talk emanates from the young person. Okay. And then the session ends with a discussion for strategies to change. So it's very driven by the young person as opposed to the healthcare provider. So that's how the intervention looks like, and it's single session, very simple, very easy to implement. So we tested this intervention for youth who are attending a clinic for youth living with HIV at MTRH. And this was a single arm pilot, a mixed method study. And we tested it for youth who are aged 15 to 24 years. And the peer providers that we trained were aged 18 to 24 years. So in Kenya, in the HIV setting, peer providers are frequently stationed there. And the work that they do is to support youth with adherence to HIV medication. So we trained them in addition to offer the screening and brief intervention. And they were actually able to acquire that skill quite well. And the training took about 5 days. And then we got feedback from the young people about their perceptions of the intervention, and also got feedback from the peer providers about how well they liked delivering the intervention. And we also got feedback from the clinic leaders about how much they, how feasible it would be to implement that intervention future. And broadly, that intervention was feasible and acceptable, and we'll see some of the feedback that we got. So the young people found it actually to be enjoyable. So one young person said, "I enjoyed the session. It was a wake-up call. I was abusing a lot of marijuana. So when I went for the session, I realized I was an abuser and I reduced, but I need to continue pushing until I stopped." So they gained some insights into their pattern of use. Another one said, "I received information about the drugs. I knew how they affect people, and I decided to leave it." So, we can see how young people began to understand, the impacts of drugs. And then concerning their perceptions about the peer providers, one said the peer was friendly, so I was comfortable asking questions. So they found that interaction with the peer provider to be acceptable. again, this was interesting. We evaluated acceptability in a second pilot using a theoretical framework that evaluates acceptability in detail, and was a construct that looks at ethicality, that particularly explores how well the brief intervention aligned with their future goals. And it was interesting that this was the feedback that we got, that the young people said that the intervention fit in with their goals of, succeeding in the future. So one young person said, it fits in with my goal of becoming a doctor, right? And they wanted to study medicine. They fit in with that goal, and they decided to leave it because it was either the medicine or the drugs, right? Very interesting. And they also said it fits in with the goal of helping their parents, right? So it also fits in with the goal of supporting future generations, right? So we can see that the brief intervention helps the individual, but also has impact on future generations. Looking into the future, the brief intervention is a very simple intervention, again, that can be delivered using digital means or even using telehealth approaches. And this can be explored in the African setting, now that people have access to phones, and particularly because also young people, are now living inside their phones. Yes, they are. So that can be explored. And then in the future also, we are looking, to test the efficacy and effectiveness in real world settings, multiple settings of the brief intervention. I'd like to acknowledge DGHI, NIH, and all the project teams at Intergenerational for their contribution to this work. Thank you.
All right. Hi, everyone. I'm Savannah. I am so thankful to be on this panel with Dr. Justo and Dr. Jujiba. As Dr. Pepper mentioned, I'm a postdoctoral fellow at Massachusetts General Hospital and Harvard Medical School. And I'm thrilled to present on the prepared intervention, which actually culminated during a lot of my time at Duke. So I'm really, really happy to be back here today. I'm going to dive in and just start with saying intimate partner violence is very, very complicated, and it's very, very challenging to interrupt once those patterns are ingrained. As Dr. Pepper mentioned, we know that it starts early. So about a fourth of 15 to 19-year-olds have already experienced intimate partner violence. With that in mind, actually, Dr. Justo, Dr. Guguga, and I collaborated on a commentary to really draw attention to this problem and the need for earlier intervention efforts. My line of research is a response to that call in thinking about how do we engage adolescents in some of this work. It has taken place in Uhuru Bay, Kenya, which is a community that should be familiar to some folks in this room. It's also the home to Wiser Girls Secondary School, and the amazing co-founder of Wiser is here, Dr. Cheryl Broverman. And Wiser has and continues to have such a profound impact on this community. It is a community, as you saw on the map, that's on the coast of Lake Victoria, and the fishing industry is a great strength, but also a contributor to great challenges as it relates to heightened rates of HIV. Uhuru Bay is also a community that has very limited infrastructure for mental health, but also for supports for survivors of violence. And so with the community advisory board in this community, we did some qualitative formative work that led to this working model to help us understand what are the motivators of dating relationships in this community, but also what is the nature of these dating relationships and how does it relate to this risk of intimate partner violence, which is quite prevalent, but also how is intimate partner violence related to mental health problems. I don't have time to walk through this whole diagram, but it speaks to how complicated this challenge exists with so many other factors at play. And so, born out of this qualitative work, Prepared was developed. And I'll run through some of the key components of how it was designed. We designed Prepare to reach adolescent boys and girls. And importantly, we included boys, which they're often left out of these conversations. And I think that speaks nicely to the importance of Dr. Giusto's work as well. If we can engage boys a little bit earlier, um, we might have fathers who also are able to engage with their families better. So it was made for 14 to 17-year-olds, and we take a universal prevention approach. So all adolescents are welcome to participate. And it's a group-based format. So we have 6 sessions that combine didactics, discussion, activities, and most excitingly, skits. And it was implemented in community-based settings, and we designed it for flexible implementation, which I'll get into a little bit later. We followed a near peer delivery model. So working with 14 to 17-year-olds, but engaging 20 to 25-year-olds to actually facilitate the intervention in hopes of that proximity being engaging for the youth. And finally, our outcomes at the individual level were to promote psychological well-being for adolescents. At the relationship level, we were hoping to reduce risk for intimate partner violence and other sexual risk-taking. So here's an outline of the intervention. You can see how we organized it to address both mental health and relationship skill building. And I'll speak a little bit to give some examples. So session 1, I'm prepared to notice my feelings. It was really an introduction to thinking about emotions and thinking about simple ways to experience them. One of the skills that we taught was 5-finger breathing. If there's any other child psychologists in the room, you probably know this skill well. But we adapted it to follow this theme of mountains and valleys and introduce the idea that there are mountains and valleys in life. But if we keep moving through our valleys, we'll be back on our mountains again. And the youth really liked the idea of that. Another example from session 3, which focuses on healthy relationship development. Impossible to read the text, but I wanted to show it as an example. These are 2 characters that go along with the whole intervention. And this visual displays a cartoon comic strip where these 2 adolescents face a problem in their dating relationship. And then they use some of the skills that they learned in the intervention to kind of show adolescents how this could be done. So we did a proof of concept pilot with 46 adolescents. 22 were in a school-based implementation. So I spoke to the flexible implementation settings, meeting adolescents where they were in the school place. In this community, a lot of adolescents don't have access to school because they are not able to come up with the school fees. So there are 14 to 17-year-olds living in the community, maybe with jobs, maybe not, but they're not being reached by any of the health promotion activities that are embedded in schools. So we worked hard to reach them too. So we had 24 in the community. And our implementation outcomes from this pilot support a successful near peer delivery. And they also support the acceptability and feasibility in both of these settings, which was really promising in reaching, especially the out of school youth. And just a very high level look at our outcomes at the individual level. These are very preliminary. We just did a pre-post survey, but our results indicated improved well-being, reduced depressive symptoms and distress, as well as increased social support, perceived social support. So it seems like youth were more open to engaging with the natural support systems in their life. And then at the relationship level, we found greater agreement with respectful and responsible approaches to partnership, both in sexual relationships and dating relationships. We also found improved communication, increased equitable decision-making. At immediate follow-up, so after the 6 weeks of the intervention, we did not see immediate effects on IPV. That being said, we just completed a 2-year follow-up study, and we're still analyzing those data, but it's looking promising that we might see some of those effects on intimate partner violence over time, which is expected to think about how complicated this is. It might take some time for those to be measured. This is just a photo of our community advisory board and some of our research assistants who are based in Mahuru Bay. Dr. Jaguga also helped in supporting the development of this intervention. So I appreciate the collaboration of all of these team members. Then I also want to acknowledge the support of this institute and of Duke in supporting this work as I completed my graduate training. And one of your amazing master's students, Lauren Lloyd, was actually on my Vast Connections team. And I really appreciate being back here to talk about this work some.
All so much for those presentations. I have questions that I'm eager to ask, but I would love for us to pause for a second and give you all an opportunity to ask questions here in the room, and then we'll see about online as well. Any initial questions people have?
Hello, my name is Hera, and firstly, thank you so much to all the panelists for the wonderful discussion and the wonderful ideas that you shared with us and how they work. My question is about this theme of peer support that keeps coming up in all three of these interventions. And I'm curious to know if there were any challenges when it comes to how open people felt talking to their peers, especially I think in the case of the mother's intervention. Like, were there any challenges? Did they feel any hesitation when it came to talking to other male peers similar to their age and their particular context? So do you think that happened, or were they like very open to those discussions?
Also, I forgot to thank Duke too. Which was instrumental. No, I'm gonna save it for later. Which was instrumental in a lot of this work. Great question. We've all used a lot of peer support. Models in our small trial, I would say it's mixed. Ultimately, people were happy to speak with their peers and was qualitatively a key facilitator in engagement. So I think I might actually have this quote memorized, but because it was just like so sweet. At the end of the pilot, like one of the fathers reported, basically like, I love my counselor. It was my reason that I kept coming back to the sessions. That they built this relationship. So I think there is a balance in the duality of the role. But I think them being seen as role models in the community and kind of some higher reputational status created a nice gateway of like, you are like me and I can see myself as you in hopefully in some time. I'm extrapolating, but it's really positive feedback about those relationships. In this larger trial, as we're getting bigger, I think there's a few complications. I think some people are going to want people from their community, and I think some people are not. So on the whole, we've seen that you don't really want someone who's in their immediate community to deliver the treatment. And we had one situation where we then switched the counselors where the patient was a former teacher of the student, and none of the counselor and the patient weren't really picking up that this might be odd, but the supervisor did. So I think also having that kind of chain of support to see so that relationship is supported, it can be facilitated hopefully appropriately is another really helpful piece of the puzzle.
Yeah. I mean, we did see mixed opinions as well, mixed feedback, but largely positive in terms of the young people enjoying to talk to the peers. One that stands out for me was that one young person said, when I got into the session, I found this age mate of mine and I wondered what a young person my age would tell me. But at the end of the session, I appreciated. So there's this initial skepticism about a young person counseling me, but then towards the end, they do appreciate it. And then there were some comments about the peers not being competent. But then such feedback helps us to refine how we train the peers, how we build their capacity. So it can never be 100%, but then negative feedback helps us to strengthen how we deliver that lay provided care.
I'll briefly add that for our intervention, we found that the youth really appreciated that these were near peer providers from their community. And when talking about things like intimate partner violence, talking about things about sexual relationships, I think it was helpful to have young people who were like, we get it. We get the expectations of this community. We've also, I mean, the facilitators were also reflective on how engaging with the intervention changed their own approaches to their dating relationships at the time. So I think that ability to learn together, but also to have just a little bit older, little bit of this mentor identity really facilitated a lot of engagement.
Thank you.
Great question.
I am Gavin Yamey. I'm a professor of global health here at DGHI. Thank you, first of all, for a fantastic panel. Dr. Jaguga mentioned cell phones, and I wanted to just continue that conversation a little bit. So we have a 9-year-old, obviously, a 9-year-old son. He's obviously never going to be allowed a cell phone ever, nor social media ever, maybe when he's like 40 or 50 or something. If I understand the evidence correctly, it's now fairly incontrovertible, and the evidence is quite robust that social media use is associated with increased risk of anxiety and depression in adolescents. So I have 2 questions. One is, how much of a problem is that in the communities in which you work? And then secondly, on December the 10th this year, Australia is banning social media for under 16-year-olds, first country in the world to do so. It's going to be probably somewhat hard to enforce, but actually there do seem to be sort of technological ways to enforce it. Do you think that's where we're heading?
You said you were banning social media.
No, really good question. I don't know that there is objective work in Kenya or Africa. I would have to check, so I don't want to authoritatively comment when I haven't looked it up. I don't know that there's work that has linked social media to mental health issues in Africa. But anecdotally, I would agree, and even theoretically, it makes sense that excessive social media use would have a lot of mental health consequences, just because of the content, and just because it takes young people and even people away from what's most productive and potentially addictive as well. So theoretically, it makes sense. But in terms of the utility of smartphones or mobile phones for delivering mental health interventions, I think that has been well documented globally and even in Africa as well. And that should be pursued. If they could ban social media, but the phones are still there for these other useful things, then I think that that would be, I mean, a good balance. Please allow your child to use the phone. It's too old.
Add on that a little bit. It actually came up a bit in our formative qualitative work, and the idea of what are the drivers of psychological distress amongst adolescents. And some of them did indicate that the idea of this celebrity influence lifestyle, and to be able to see that on your phone and then live in a rural setting where there's no real like celebrity life like that they can see in real life, I think is really disorienting.
Yep.
And I think that the gap between that was also very depressing. And so it wasn't included in our survey, but it did come up numerous times in these qualitative interviews. So I do think that there's something to be said about this line of questioning around that. As far as your other question about, is this where we're headed? I do clinical work at MGH with adolescents, and I leave those sessions thinking about how much of this distress could have been prevented if they weren't staring at a phone. And I do think that it's real, and I think that there aren't good answers yet. I'll be eager to hear how it goes in Australia. But I think there really is a huge question for this generation of parents and for this generation of young people. What is the relationship with technology going to be?
Yeah. You want to say too, and add on, because I think you're getting to the heart of it too, is the nuance of it and how nothing is ever a one size fit all. And that I think a lot of the evidence that is coming out has been very broad stroke in time spent on screen and outcomes. But if you dig into some of the literature, for some kids, they're fine. or they're going for positive experience and social connection. And when they're doing that, some things you're seeing even positive affect moments. And for some kids, they're not fine. And I think we're just digging into who is fine with what and what are they looking at? Am I comparing? Am I engaging in this when I am feeling depressed and feeling more depressed? Am I engaging in this when I want to tell Florence, like, my kid just started walking or something, and sharing that news? And so I think if we can take within our research context nuance into how we're understanding the function and the use of those tools, because I think there could be a really sad thing that happens. I do think there's probably a group of kiddos, especially maybe from in marginalized identities or marginalized communities, who are really using this to connect and also see. And I think we're all figuring that all out, and I don't know what that looks like, but I like the thinking of it with all this nuance of like what's working for whom and how.
Thank you so much, both of you guys, for the amazing presentations. I wanted to ask about the intervention with fathers and how there was like a specific module about masculinity. And I wondered, was there any kind of like pushback of a masculinity model that was coming from a lot of, I know not the entire research team is not from the United States, but like a large part of it. Was there any kind of like pushback against a masculinity model that can maybe use like a Western cultural framework? Or did you feel like the masculinity models that they kind of discussed throughout the workshop was rooted in like local cultures and identity?
Good question. We based on the program called Pro Mundo, which is global, has a lot of work in sub-Saharan Africa and Latin America. And what we try to do as much as we can, and in part of why we chose behavioral activation and MI as sort of core engines of the treatment, is they're really based in however that person is defining the thing for them. But what is your value? What is your, what's it like for you? So we, I want to be mindful, I'm fully answering your question, so I was just pausing to think. My brain is like this. That we ask, we're not saying, okay, this is what it's like to be a man, or this is like, or these are the examples. It kind of starts, more the gateway in is, I'd love to hear about how you grew up. Tell me about what your dad was like. What is something that reminds you, if you don't have a father, the person that helped raise you, or someone in your community that you might have looked up to? What's something that reminds you of them? So we try to really be open-ended and then kind of funnel down into some of the specific behaviors around however that person is defining that. I'm sure there are probably some imperfections in there, but trying to really be as patient-led as possible, and not imposing any models. I will say, which is not exactly answering your question, I think the patients responded really well to this, and I think the counselors sometimes felt a little bit uncomfortable asking these questions. And they did great too. So it was funny, their qualitative stuff at the end was like, that was a little bit complicated. It's a little more off book. It's like a little more off manual. And so making sure they felt supported in training and feeling if they wanted to self-disclose or not self-disclose, how to navigate that dynamic. I think in the therapeutic relationship is interesting. But we would try to be really mindful of that, and keep thinking about it as we go.
Thank you so much for your presentation. My name is Annie. And I really like the point about how a lot of the interventions focus not only on the deficit, but on empowerment and the skill sets that were to go in the long run. I'm a little curious about how these interventions could be sort of implemented in a longer time span. Maybe like after all the efficacy tests were done, like how maybe like the local health facilitators could adopt, or is there any ways to integrate these programs in the local setting so it's very accessible in the long run? Because I did hear, and like a lot of the interventions seems to have a very well long-term like effectiveness across like, a lot of the patients that are tested. So I'm interested in knowing how maybe the local government or like health facilitators could collaborate with these interventions and figure out ways where they can be self-sufficient.
Yeah, I mean, that's a very important question, very great question. And they say that the time between evidence generation and translation to policy and practice can be 10, 20 years or even never. All right. And as researchers, we should concern ourselves with translation of evidence to policy and practice. So that means we should think about it from the design stage of the research. And what we are beginning to do with the projects that we design now is having policymakers on board from the beginning. So traditionally, we've conducted research by ourselves as researchers and not thought about scaling up or translation to policy at the beginning. You want to get your PhD and you're done. But then we don't reap the maximum benefit from such an approach. So it's changing and you have to think about it from the beginning. So for example, in thinking about the work that Ali is doing, or the whole team here, we design the interventions with policymakers. We think about barriers and facilitators with policymakers. We refine the intervention with policymakers. We think about implementation strategy with policymakers and with the community and with the government. And then we disseminate the findings to the policymakers. So it's not a straight line, it's a roundabout line. And you have to think about, and even in disseminating, you don't disseminate like how you would talk in a scientific conference. You develop what you call policy briefs. You communicate in a language that is simple. So it's all these strategies that are multifaceted and that are not necessarily scientific in nature. It means also forming friendships and relationships with policymakers. It's not a science, it's an art. It's slightly different than how you would, it's different. And then it means that you lobby to be in a working group in the Ministry of Health, for example. And when you sit in that working group, you share your findings, you talk about your agenda, right? If there's a policy document being developed, you're contributing to it. You're pushing your agenda of intimate partner violence or alcohol, for example, which is what we enjoy with Ali. So when I'm in the Ministry of Health, I make sure I'm pushing this agenda, right? That is what it is. It's not a step 1, 2, 3, like the brief intervention we presented or like what you presented for IPP. It's slightly different and it's an art. And you think about it from the design stage of intervention.
I realize I've ignored the people online. Maeve tells me there are a couple of questions. Let's take one of those before we wrap up.
Thanks y'all so much. Actually, building upon Dr. Jaguga's response, there is a really interesting question about how we can support policymakers in prioritizing resource allocation for mental health interventions, both in low and middle income countries, but also in high income countries. So if you had like a message to policymakers about how to prioritize mental health services, what would you say?
Okay. You've put me on this. One single message, really? Is there one single message? There's many different messages, mostly because the gap is huge. And there's all these different aspects that need to be prioritized, the thing that they could do quickest that could have the greatest impact is to scale up community-based, non-specialist care. That would reach the broadest, that would reach the population, the largest population quickest. If you ask me, it may not be popular, it will need a lot of, advocacy, but for me, that would be the quickest. Like my thoughts now are to think about how do we, link lay provided care with the healthcare system. How do we formalize lay provided care so that there's a clear pathway between lay provider care and the healthcare system? So this intervention, for example, that is being tested by Ali, it's amazing. How can it be scaled up? And then how can we link fathers to the healthcare system? How can healthcare system provide supervision for the lay care provider? So that kind of thing for me would be a priority.
Thank you all so much. I think we are out of time almost. And so I just want to finish by thanking you all for your excellent questions and pointing out a couple of things that I would love for you to follow up with these panelists about is the idea of scale up that Lawrence just mentioned, and a couple of things about that. One, I'm so glad, Gavin, you pushing us to think about many aspects of digital health and illness related to digital exposure, but how we can think about novel approaches to scale up. And some of that is digital, some of that is integration into the health system, and a lot of non-specialist providers, because a lot of these people are natural helpers in their community. They are doing this at a scalable level. They have been scaled, helpful people in the community, and how we can partner with them. And then the other piece that we've been thinking a lot about, but you all work all over the world. And so we'd love to also think about ways to adapt these types of approaches and think about integrating family-based care along with individual-based care across settings, recognizing the multiple layers of influence, not just on kids. That's what we think a lot about, but also on all of the adults that you see. They don't live in a vacuum. And so we would love to keep the conversation going with all of us in the room about how we can think about those multiple layers and take advantage of our very limited resources to use some of those same resources, same individuals, same community advisory board, same health systems to act at multiple levels all at once. So would love questions about that, critiques of that, ideas and questions, not just today, but I'll give our email addresses again in any way that you would like to engage with us. But thank you so much for your attention. Thank you to everyone on Zoom, but we really appreciate your time.